first speaker is Dr. Parveen Kumar Monga. Please. The topic is health insurance, patient's perspective versus clinician's perspective.
Good morning, everyone. Good morning, dignitaries on the dais, off the dais. I'll be presenting my views on health insurance, patient's perspective as versus clinician's perspective. No financial disclosure. Just to set the pretext of my talk, I did a small survey on the how much health insurance is important. I took data from various types of eye centers to check the volume as well as revenue from various insured and empaneled cases. Like you can see data from standalone eye center where only 2 eye surgeons were there. Revenue from insured, I took data, I compared data from for 3 months in various years. So revenue in a standalone eye center was 28% in March 2021, and in 2023 it was approximately 35%. Similarly, an eye center as a part of corporate chain in North India, it was 47%, 55 and 45% in various months, different years. From again the data from large eye center as part of corporate chain, 42% and risen to 68% in 2023. And similar data was from eye center as part of corporate chain from Eastern India. The crux is basically what is the inference from this survey, that it was very obvious that volume and revenue from insured as well as empaneled cases from various government schemes, health schemes, it was significant in terms of volume as well as revenue, and it had showed northward trend. And definitely out of pocket cases are decreasing. So after this pretext, what does the patient want from health insurance? Patient wants services from a well recognized center which is providing high quality services. Patient wants personalized or customized services. He wants the highest the quality of consumables in ophthalmology. Most important, most common surgery is cataract, so highest quality of intraocular lens patient wants, and he doesn't want any co-payment, and he wants all the reimbursement for consultations, investigations and all other consumables, and he wants very less cool off periods. Though in ophthalmology this is not this concern is not very important, but for other services he wants higher category of room, and he wants cover for pre as well as post hospitalization expenses and no deductibles. And most of the times patients are not sure about terms and conditions of his insurance plan, so he wants transparency. And at the same time, what does clinician what do we want? We want best package rates for our services, and there should be very less documentation for pre-authorization of the insurance plan, and after the surgery for settlement of packages, the documentation again should be easy and minimal. And we also want complete reimbursement for all investigations, consultations and consumables, and we want the settlement to be done as early as possible after the surgery. Similarly, we also as clinicians, so many times we don't know the actual terms and conditions of patient's insurance plan, so we also want transparency of terms and conditions along with the patients. And what happens in the same area, for the similar surgery, different packages are there for different hospitals. So we want the similar packages in at least that area to reduce the competition in that sense. And how to create that win-win situation. For a patient, if patient can buy a group insurance plan like corporate insurance, if we don't have corporate insurance, we can, as patient, we can club together and take a combined plan. And all better to take plan with higher sublimit. Like supposedly we have a plan of 5 lakh with star insurance, and the sublimit for cataract surgery is 25,000. We should bargain before taking plan that sublimit should be higher, not that low. Then before buying the insurance plan, inquire about deductibles and co-payments. The difference between deductibles and co-payments is deductible is the amount after which your insurance starts. Supposedly you have a bill of 1 lakh rupees and your deductible is 20,000 rupees. So insurance company will start reimbursing your claim after 20,000 rupees. So rest 80,000 will be paid by the insurance company, and the co-payment is it's in the terms of percentage. Like if it is 10% co-payment, is your bill is 1 lakh, insurance company will pay 90%, 10% you have to bear. Like in another example, if bill is 1,50,000, in co-payment of 10%, insurance company will deduct 15,000. However, in deductibles, insurance company will give 1,30,000. Initial 20,000 insurance company will not pay. And a patient wants for elective surgeries, all elective procedures, insurance company does not reimburse the money before some period. Like for cataract surgery, in most of the insurance companies, there is cooling off period of 2 years. Only after 2 years, insurance patient can go for elective surgery like cataract surgery. Again, before buying the insurance, we should have knowledge of pre and post hospitalization expenses. And definitely, if you want as patient, if you want cashless treatment, better to choose the center in network of that particular insurance. For clinician, few tips for the clinician. Definitely, if we can get our organization accredited with some known body like NABH, the empanelment is easy, as well as extra remuneration is also there for few cases. For example, in Haryana government gives extra reimbursement of 15% if NABH full accredited is there. Just I will finish. And definitely bargain hard with insurance providers. You can take IOL exclusive as well as inclusive packages, and know the sublimit of insurance and bill accordingly the patient. Meticulous and thorough documentation should be there. And you should, as clinicians, you should know the process of settlement of so many insurance companies, they want hard copies also along with the soft copies. And while making bills, stick to the agreed tariff plans as per MOU. And just post text with I think it's not moving. Just go to the last slide, concluding, sir. Just as post text, whether accreditation is required or not. Initially it was a must, but now after so many extensions, IRDA has given that it is not mandatory now. Insurance company can empanel hospitals even without NABH accreditation, but TPAs should they have their own standards and their own, they can conduct their own inspection. And there is recent development in insurance area that General Insurance Council has set up a committee to establish a common empanelment list and common rates for various procedures. That it should be same package rates for all the hospitals throughout the India. How successful they will be, the time will tell. Just as a concluding remark, nowadays insurance and other empanelments are not, it has not remained luxury, but it is our fight for survival, and our insurance company, we have to make it patient friendly, and documentation has to be thorough and meticulous. And now the dynamic will shift from a relationship where physicians and insurance companies are counterparties with competing interests. Now we have to move towards an association where our interests are aligned towards a common goal of improving health of the people we serve. Thank you very much, sir.
Excellent presentation, Dr. Ravi. Any comments? Okay. Next presentation is by Dr. Lippi, Creative Approach to Awareness of Ophthalmic Disease in Central India.
Yeah, so hello all. This is a comprehensive session, a community session, and that's a topic I have chosen. Nayan Rangoli and Nayano Ki Boli, Creative Approach to Awareness of Ophthalmic Disease in Central India. Those who are from Hindi-speaking states, they can relate to the title better. No financial disclosures. Visual impairment in India, we still have cataract, refractive error, glaucoma, diabetic retinopathy, all these causes to be the prime causes of visual impairment, though the percentage of cataract that has fallen, the prevalence has fallen, but still it remains as one of the important causes of visual impairment in India. As per IAPB and World Health Organization, our efforts from the clinicians, that should be people-centered and putting people and communities and not diseases at the center of health, that should be our concern. And for this, we need to do implementation of all possible eye care promotion strategies. So keeping this in mind, we aimed to use innovative methods of scientific rangolis, we termed them as Nayan Rangolis, and educative songs, Nayano Ki Boli, for raising awareness and knowledge of common ophthalmic diseases among patients and general population. So this was a prospective medical college hospital-based study. Observances dedicated to eye health are identified. So what are these observances? Like now we have the World Sight Day going on, we have Diabetic Awareness Month, Cataract Awareness Month, glaucoma, so like that, these are the observances, identified months or fortnight, weeks for certain diseases. Promotion of awareness and knowledge of ophthalmic entities was undertaken in the related observance month in the form of innovative scientific rangolis and educative songs. So these are some of the observances. These were the rangolis made. Now I'll be going to the video without wasting much of my time. I hope this plays, because at certain places, in certain conferences, this does not. Can we have the audio? Audio switch on karenge, please. High, make it high. बढ़ा देंगे, audio बढ़ाएंगे. Audio बढ़ाएंगे. Audio बढ़ाएंगे. Yeah, thank you.
A contemporary creative approach to ophthalmic mass education. Informal traditional methods of health education in the form of role plays, songs, poems, games, art has been used. Herein presenting an approach that is appealing, engrossing, comprehensible, and connecting to the audience.
बाबूजी चेकअप करना, डायबिटीज से संभलना, इन्फेक्शन होते हैं, नजर भी खोते हैं इस रोग में. बाबूजी चेकअप करना, डायबिटीज से संभलना, इन्फेक्शन होते हैं, नजर भी खोते हैं इस रोग में. बाबूजी चेकअप करना.
So this is just for everyone's enjoyment.
Rangolis and educative songs related to ocular health and common ophthalmic diseases were fashioned. The volunteering interns and medical students explained the rangolis to interested audience and encouraged them for ophthalmic examination. काला मोतिया को कांच बिंदु या ग्लॉकोमा भी कहा जाता है. इस रोग में आंख का प्रेशर बढ़ जाता है. तो आइए जाने आखिर क्या है ये काला मोतिया.
क्या है काला मोतिया, क्या है काला मोतिया, क्या है काला मोतिया, क्या है काला मोतिया.
आंख का पानी बड़ा, आंख का प्रेशर बड़ा.
यही काला मोतिया, यही काला मोतिया.
आंख का पानी बड़ा, आंख का प्रेशर बड़ा.
यही काला मोतिया, यही काला मोतिया.
काला मोतिया अक्सर बाहरी दृष्टि क्षेत्र में कमी होती है. दृष्टि क्षेत्र में अन्य दोष भी पाए जाते हैं.
आजू बाजू की चीजें दिखेंगी. videos were played across the hospital, across the community, and on social media platforms.
ये क्या हुआ? ये क्या हुआ? अरे भाई क्या हुआ?
सर्दी खांसी ना मलेरिया हुआ, सर्दी खांसी ना मलेरिया हुआ, ऑपरेशन करवा ले तुझको, मोती 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 मोतियाबिंद हुआ, मोती मोती मोती।
This creative method was found to be more attractive as compared to medical posters and lectures. The process engaged, educated, and entertained the students, their staff, and the patients across all ages.
So this is Dadiji who was operated. The child is even picking up the song and singing it.
Let's spread intelligence with creativity and fun. Nayan Rangoli and Nayan Boli have just begun.
Okay, so now the video says it all. We know that materials, they need to be developed in health science, and they are to be pilot tested to ensure that the messages are correctly interpreted and understood. Information from other community members, internet and social media, they have been found to be leading source of eye-related information. We should target certain groups of the population who cannot understand our lectures and posters. So women, older age, lower literacy patients. Remarkable potential exists to combine arts engagement with knowledge translation. So this is what our approach is all about. These are my references. Thank you so much for enjoying the presentation. Thank you.
Thanks, Lipin.
Yeah.
But some portions make it English because we.
The last slide एक बार दिखा देंगे. Last slide. I think they switched it off before as soon as I completed. Yeah, so this is something I termed as Netra Ludo. And this is actually subsidy. This was made during COVID period, and pediatric population, they enjoyed playing this. Yes, sir, you were telling something.
In
Sorry.
English also.
Yeah, but ours is a Hindi.
We understanding Hindi now. That
Yeah,
is
yeah.
the whole.
If I am
when it is a
practicing-
national conference,
Right.
at least English will be better.
Right.
Okay,
sir,
thank you, Lipi.
right. Yeah,
thank you very much.
Thank you.
Yeah, thank you, Lipi, for presenting this creative approach. The next speaker is Dr. Soumya HV, who will speak on teach and assess surgical skills in ophthalmology, the Oscar way.
Very good afternoon, everyone, and I am very grateful to AIOS for having given me this opportunity to speak about Oscar. Now, slides. Oscar, be it on the entertainment front or in the educative field, it's the ultimate. Now, we have 7 competencies which are much spoken about in the field of ophthalmology: the medical knowledge, the patient care, practice-based learning, interpersonal and communication skills, professionalism, systems-based practice, and last but not all the least is seventh area of competence, the surgery, that was subsequently included. In fact, all of us do know that we teach and assess the skills of ophthalmology residents, and the most important attribute which is directly related to the patient outcome is the surgery. That's the 7th competency that was subsequently included. Now, learning how to perform surgeries can be definitely one of the daunting tasks, and that we all have gone through. We all have been taught. We also teach our residents, and then we also probably help them to ascend in the scale of being a novice, being a beginner, advanced beginner, competent, and an expert. Now, we all know that exit exams only test the cognitive knowledge of a postgraduate student, and the degree would be awarded based on the performance in the exit exams. But surgical skills definitely are not formally assessed, and they do not form a prerequisite to exit residency. So assessment of surgical skills definitely is a need of the hour. Now, why do we need assessment? That's because it is dependent both on the psychomotor as well as the cognitive proficiency. Now, they have to master the cognitive knowledge and do apply them in their professional career wherever they start after the completion of residency. Now, institutions definitely may stress on the quantity, but the quality definitely may differ. And surgical educators definitely have expressed concern that their residents may lack confidence and competence among the after the graduation, and many of them may not continue to go for a fellowship and may start from their private practice soon after the completion of the residency. So definitely assessment of the surgical skills will provide an insight to the teachers now how well or how efficiently you can make a resident develop into a good surgeon. Now, do we only do assess or teach? No, both of them definitely go hand in hand. It's something called as we teach to assess and then we assess to teach. Now, it could be either in the form of a summative assessment or a formative assessment, whereas summative is at the generally, probably we take it similar to that of a university exams, or a formative assessment is done in the middle so that we know at this particular stage the resident needs to put more effort or needs to put more interest into whatever it is being done. Now, what are the principles of assessment? Time, it is valuable, limited, and then you are testing the application of the knowledge and skills rather than just facts. And more important is that particular situation. So if you're assessing the postgraduate on that particular day, because you cannot conclude and say that she has been doing well from the past probably 6 months and today she is not able to perform. On that day, whatever, or the situation specific, the performance has to be assessed. And define assessments clearly in advance. Tell the students that we'll be assessing your surgeries today, or probably we'll just monitor how you're performing the surgery today. Now, we have been doing this definitely, even though there is no structured way, we definitely teach, we definitely assess the skills of the residents. But there is something called a rubric, which helps us to do it in a structured way. Uniformity and standard decreases the subjectivity of the assessment. That is, even different evaluators can use the same rubric and assess the skill of the residents. And defines for the assessor also. So the assessor also would know what behavior of the student is to be assessed or what step of the resident is to be assessed. Now, what are the tools that are available? There are many different tools that are available, like OASIS, which was the first one which objectively assessed the surgical skill competency, and OSACs and HRACS, and some of them definitely saw the videos of the residents, the surgeries of the residents being performed, and then they graded. But we in our institute use the ICO Oscar, that is the International Council of Ophthalmology, objective structured assessment of the rubric. And then we brought out an interesting study that we assess the skills, or we assess the particular steps of the residents, and then we evaluated them, we gave the number, and we also asked the residents to grade their own surgery, and we tried to compare the two results and tell them at what particular step they needed little bit of improvement. Now, this is something known as OASIS. This is GRASIS. I'll just go into the details of Oscar. This is HRACS. The next one is making of Oscar. Now, what is this? It is Ophthalmology Surgical Competency Assessment Rubric. Now, how was it done? So the 15 international ophthalmologists used something called as the Dreyfus model of skill acquisition, wherein they again went through the document of OSACs, and then they modified it, and then applied the concept of Dreyfus model of skill acquisition, and then for each level they started giving marks, and then for globally acceptable rubric was done. Now, this was approved by International Council of Ophthalmology as an assessment tool, And then face and content validity was also established. Now, if we type ICU Oscar, we have rubrics for all types of surgeries, including ECC, SICS, phaco, squint surgeries, trabeculectomies, and also for pan-retinal photocoagulation and other procedures that is done. Now, how does this look? So this is how the ICU Oscar tools look if we search in the website. There are different tools available for different types of surgeries. Now, what did we do here? Here, in each chart, each step will be written. And for each step, we have 5 different levels. That is the novice, the early beginner, the advanced beginner, the competent, and the expert. Now, each will be given marking, 0, 1, 2, 3, 4. Now, the resident after the surgery has to simply circle. Probably today, the resident was not able to maintain tissues properly, in the sense excessive handling of tissues. So it has an explanation when if it is an excessive handling, you'll have to give a number for the same. So the resident would take a copy, that's what we did, take a copy of the printout and then circle whichever category on that day the surgery was being done. It has to simply be circled. At the end of the case, it has to be completed. And then we as faculty immediately gave the feedback after that particular case. So then we tried to compare the results of the faculty as well as the resident. Now, if different people are doing, then we had a consensus that initially only we saw the printout and then we said this particular step, this is the way it would be assessed. So all of us came into a single consensus. Now, this is the ICO rubric. There are different indices, global indices also, which gives importance to the tissue handling. Now, how did we use Oscar? So it was monitored, and when we gave her we initially gave the printout, we made her to read the printout and then discussed about it, and then after the surgery, she was made to give points to her surgery, and then we evaluated. Now, the important thing, there was a scope for self-evaluation. There was a comparison between the trainee and the trainer. We repeatedly administered the rubric, and we also got feedback from the residents. Now, the results showed that there was a significant difference between the first case and the last case. And especially this difference was very significant in the second-year students, because initially they were not exposed to much surgeries. But the difference was not much in the final year because already they were doing surgery, so they improved marginally. And the faculty feedback also had a similar results when compared to that of the student results. Now, the feedback was, yes, it definitely helps us both as an assessment tool and as well as a teaching tool. Now, conclusions, the rubric definitely gives us what patterns of behavior are expected in a resident, and therefore we can follow it up, we can evaluate and help them to become a good expert in their surgical career. Now, Oscar is preferred because...
Adjust to the time. Yes. That is very important. Thank you.
Thank you very much. Excellent presentation. Next presentation is by Dr. Stakar. His topic is financial literacy for the young ophthalmologists.
Good morning. This is designed for DNBs or people in the first 5 years of their lives. So seniors, you can give me tips, okay, and give them also tips. Slides, okay. Yeah. Thank you. So financial literacy for the young ophthalmologist. Okay, so why this talk? Financial topic or financial planning is not covered at all, either in MBBS or DO or MS curriculums. Soft skill communications also, which are very important for doctors, are also not covered, but we see it in real life. We observe our consultants, we learn from our seniors, learning the art in vivo rather than in the abstract theory that is there in the books. We hardly have any open discussions on financial needs or planning, either with our colleagues or with consultants. So the first disclaimer is I am not a certified financial planner. This talk is only meant to sensitize the postgraduates so that you have the advantage of starting early enough so that you may reap the maximum benefits. So what fills up contents of dozens of channels, newspapers, blogs, and books cannot obviously be simplified in just 7 minutes. So anybody recognize this person? Warren Buffett. So Warren Buffett was worth $10,000 at the age of 26, but now he's worth over $100 billion. So, and the trick is that over 90% of his wealth was actually created after he turned 65. Okay. So the trick or the secret is the magic of compounding. So you have to start early as possible, systematic investing, and the effect of confounding the compounding variables are there. So these are some basics. The average salary in India is about 33,000 rupees. Earning 1 lakh per month puts you on the top 10% of income earners. Okay, you might think that's small, but that is what people declare. Okay, the PG stipend, as far as you know, in most states is about over 50,000 per month. Okay, so you're already earning 6 lakhs per month. If you know that your your salary, or you think it's a stipend, but the government considered it a salary. So you are a salaried person at 6 lakhs per month. Virtually now the tax regimes have changed significantly over the last 2 years. We have something called the Section 44 ADA, by which you can make your entire 6 lakh salary virtually tax free. You don't have to pay a rupee of tax as long as you put a small investment in some place. So the normal 50-30-20 budget rule. Okay, this is for an average salary. So I'm talking about a 33. For you being single and earning much more than the average salary, you should be able to put more into savings and investments rather than what is actually displayed or suggested here. So 50% of your salary should go towards your needs, which is your food, your room rent, your mobile bill, etc., petrol bill if you have a vehicle, and so on. 30% is for your wants. So these are not your needs to survive, but your wants. A fancy dress, a great party in the weekend. We have allocations for that. And 20% is for your savings and debt. So that means in case savings is of course for future, and debt is in case you've taken a loan, an education loan, a bike loan, a car loan, whatever you want. Okay, but I said this is 50-30-20 is for the basic salary. As you being single and your needs being little, you should be able to probably push up that savings to 30% of your 60,000 or 50,000 salary that you're getting. So this is a very simple example of the magic of compounding. This I've taken PPF because the returns are predictable. The very small variable, which is the government rate of interest, okay, which varies not more than 0.5%. If you go into equities and shares and things like that, the variable component is much more difficult to predict. So this I've taken a predictable this thing. So the blue bars is what you are contributing. I've taken a starting figure of 1.5 lakhs because this is what your tax benefit is. So the blue, if you see the ascending of the blue bar, it's a straight line. There's a straight slope. Whereas if you see the green bars, that is the addition that you are getting, your earnings from that deposit that you're getting. So you see initially the bars are very small. But as the time progresses, your bars go bigger and bigger and bigger. And that's called the magic of compounding. So for an example, as an illustration, if you see the right-hand corner, for 15 years, you have put 1.5 lakhs a year. At the end of it, you're going to have a corpus of 40.5 lakhs. So if your child, you are born today and you start with a PPF, okay, when he is 15, just about to get into class 12, okay, he is going to have already 45 lakhs in his name. So this is the simplest thing that you can plan for a professional education. You extend that by another 5 years, your corpus is going to go up to, even though you've added only 7 lakhs in between, your corpus is going to go up to 66 lakhs, the lower left. You extend for another 5 years, he doesn't need, he got a merit seat, so you have that, save that money. So you want to push it to his wedding, okay, which is 25, 30 years down the line, you're going to have 1 crore in corpus for him, okay, or him or her. So that is the magic of compounding. The longer you stay invested, the bigger is the bonus that you get at the end of it. So financial planning is actually failing to plan, which means we are right now so interested in our medical education that we fail to look at this. But failing to plan is actually planning to fail later. In the sense, as doctors, you are assured of a good quality of life, definitely. But you want that good to be excellent, or you want to drive a Merc somewhere down the line. That can be a goal. It's a very valid goal. But you need to plan ahead for such an investment. So what all you need to plan for? You can plan for higher education, a paid fellowships, and abroad fellowships. You can plan for a house, a car, the marriage. This is probably, most of the literature is from the West, but marriage is taken care of by either your father or your father-in-law. So that is one goal is less for you, but the other things do carry on, okay? So your children's education, your vacation abroad, your conference abroad, finally your private clinic, and then retirement. And what are the things you look for? Inflation is the biggest bugbear that we do not take into consideration. Average, till now, average is about 6%. So if you say 72 divided by 6 is 12 years, your purchasing inflation will eat into your savings. You have 1 lakh in your savings account, 12 years later, its actual purchasing capacity is only 50,000 of what is today. So if your category B medical seat today is 25 lakhs per year, right now it's I think 12 to 13 lakhs. But when you look at 6 years down the line, that is going to double. Your category B medical seat for your child is going to be roughly approximately 30 to 40 lakhs per year. So you can't look at today's prices. So just how your earnings will come down, the cost of things are going to go up in future. And of course, go slow on taxes, plan ahead, and you can intelligently plan your taxes. Luckily, tax thing has become much simpler, I told you, with the section 44 ADA. The most important part of financial planning is goal setting. So what is goal setting? You can have various goals depending on which stage of life you are. You're young and unmarried, obviously your lifestyle expenses, to get married, marriage expenses, rent and savings for the first home. Once you're married and you're a young family, you can think of a honeymoon or buying a car, a more premium mansion. A family with young children, now you start planning for their education. A mid-mature family, you have to start planning for your own thing. Okay? So the main thing is each goal should be SMART goals. What are SMART? S is specific, measurable, attainable, relevant, and time-bound. Okay, can I take 2 minutes? Yeah, 1 minute, okay. So specific, I said, a marriage, an apartment, a car. Measurable, what is the value of that? Okay, and considering the inflation. Is it attainable? As a PG, it might be fancy to want to earn a Maybach, but you have to have realistic goals, okay, relevant to you. And finally, it is time-bound. It's not a vague this thing. So you have roughly 5 years or 6 years ahead that you want this. So therefore, you can take into consideration the kind of investment and the inflation costs that add to it. Okay, this is the risk factor. So each age group has a risk factor. So the younger you are, you can take a greater risk because then you have more time to correct if something goes wrong with it. Okay, so the youngest people have the lowest risk, and the retirees obviously have the highest risk. So financial security is like a three-legged stool resting on savings, insurance, and investments. These are separate stools, don't mix. Don't mix your drinks, don't mix your investments. Okay, so a lot of people will, all the three combined, the people will come to you with attractive plans called ULIPs and so on, but at the same time, you're not going to be. There's enough knowledge now available in your mobile, just read, okay? The biggest thing is like a term plan. Now, how many of you are in 25? You could probably get 1 crore of insurance by just paying 10,000 or 11,000 per year, okay? How many of you contribute that 50,000, part of it you're sending home, which means you've come from a place where that 50,000 matters, okay? Today, tomorrow, you cannot predict anything. Even a lightning can strike you, not that we want it to. So you need to maximize your insurance cost because your family has invested 25 years of supporting you and putting you through a good education. You need to take care of them and plan for something that can happen untowardly. Okay. I told you savings is very easy. The worst thing is, as young people, look at equities, ETFs, or mutual funds. The percentage of your portfolio should be 100 minus your age. So if you're 30 years age, 70% of what you are saving today should go into equities or mutual funds or ETFs, depending on how much time you have time to research them. The other physical assets are very immobile. It's good to have gold, good to have land, good to have home, but it is going to be extremely difficult for you to dispose of it when you need something, okay? So taking care of yourself, nobody else can care of that. Okay, so taking care of yourself is, first thing is get a good education, medical education, get good surgery, get surgical skills before stepping out. And once you take care of yourself, then you will be in a capacity to take care of your elders and your family. Thank you.
Thank you, Dr. Sudhakar. Now the next presentation is by Dr. Rathi Varsha, Health Economics of Mobile Diagnostic Van.
Good afternoon, everyone. From the economics of ours, this is about economics of mobile diagnostic van, what we are using. you must have heard about cost benefit, cost effectiveness, or cost utility analysis, and also the cost minimization. So there are various interventions either in the monetary form, the gains may be in terms of cash or quality of life, and there are certain concerns. So these are the terms which are commonly used in health economics. We know that the number of people with vision loss is growing as per the IAPB Atlas, which is there on the net, and it is going to increase to 780 million. And also the patients who are going to have diabetic retinopathy, what we have seen today in the morning, and also from the literature. So number of patients having vision-threatening diabetic retinopathy or having some amount of retinopathy is going to increase. We have shown that risk factors for poor vision in our Andhra Pradesh eye disease study as age, female, illiterate ones, those who have lower level of education, smokers, and alcoholics. And this high incidence, initially we thought that it reflects the poor access to eye care, and that is what the genesis of LVPI's eye health pyramid, what we have in 4 states, including state of Andhra Pradesh. We have a tertiary center here at Vizag. We know that mobile units have been used in areas of tsunami, earthquake, patients who have diabetic projects are running in India, mobile vans for x-rays, and also dental clinics on mobile van. So this is about mobile diagnostic van, what we have with the diagnostic equipment. The purpose here is to report the diagnostic van model for doing diagnostics in the secondary centers in remote, rural, and indigenous areas. We started this in this state in Andhra in August 2019. I'm going to present here data of Jan to December 2022. We have 2 types of investigations, like fixed facility where we will have all investigations at one place and patient will be moving. And we have a van where the van carries all the diagnostic equipment and moves from one village or one center to the other center. Based on the investigations, we can manage patients either locally or we may have to refer them to higher centers, as this information would lead a more tailored treatment for the patients. So these are the various equipment which we have used in the van. And based on the equipment and the vehicle cost, the total cost of the van is 1 crore 11 lakhs. And the investigation and charges in the rural setup would be lesser compared to what we have in metro cities or tertiary centers. So there is definitely a difference in that. And various subspecialties would have certain investigations. And this is the cost of running the van. If we remove the cost of admin, this cost would still go down to, say, 65,000. Considering for the patient, the transport costs, the daily wages, whether patient has to have a single trip and we can take care of that, or multiple trips to higher center. This was IRB approved study. The study period, as I said, is Jan to December. 5 centers each in Orissa, Andhra, and Telangana state were included. And we had these are the number of visits and patients, because one patient may have more investigation compared to the other one. We had a few patients who were following up with us and then we did investigation, or patients who had come to us for the first time, we did investigation and then we didn't have to have their visits for future. So these are total 2470. We could manage 90% of patients locally and we just had to refer 9.96% of patients. As you can see here, most of the patients are like above the age of 60 years, because these are the patients who would need someone to accompany them, and they have to go to tertiary center, so we could take care of them. 46% of female, 47% of investigations what we have done are non-paying, and 90% patients had multiple visits earlier with us. So we could manage 90% of patients and had to refer only 10% of patients. And most of the investigations what we have done are for retina, followed by glaucoma and other investigations. So these are again, based on their first visit, we could still take care of most of the patients, and only 9.9% patients had to be referred. Subspecialty wise, if we see, 82% could be managed for cornea at secondary center itself, and these are the various percentages, and only 90% we had to, 90% we could manage for anything, whatever we say. So if we consider that, we could avoid on an average 3 visits to tertiary center for these patients, and we could save the amount of money for these patients. The average cost saving per patient, if we include wage and travel cost, was also, as mentioned, 7,600. So if we consider that capital lasts for 5 years, the annual cost is 1 crore 11 lakhs, and staff cost, if we reduce the admin salary, then it is just 65,000. So cost per patient in our study was 912 rupees. And because we started 1 van late, as we continue sending these vehicles to the secondary center, probably with more number of investigations, this cost will go down further in future. So we could reach the target population where symptoms was known and we had to do investigations. We could advise those elderly people who have comorbidities like diabetes and blood pressure are taken care of in this. And if we have a faculty visiting there, we can take care of those patients at that time. Because of if faculty is around, we can take the decision immediately. But with the teleconsult facility, what we have now, we can still do that, whether the faculty is there or not. And we can avoid the visits for the patients. If we think that we just want to do for retina only or for glaucoma only, then it is very difficult to for the cost recovery from one van. And HR also is needed. Vehicle sometimes breaks down and we have to take care of those things. This is just to give you an example. On a clinical examination, when we could see a split reflex, we had done investigations like topography and pachymetry, and then, as we all know, we could identify keratoconus and take care of the patient. So this is how probably we can help the patient in a better way. So we can avoid patient's visit and we can save money for the patient. We can manage them locally as when required, we can refer them. Locations based on the disease we can change if required. And investigations can be added because initially we had added specular also, but we had hardly done 6 speculars in the beginning, so we had stopped that, and referrals can be looked into. These are just the photos of vans.
Excellent presentation.
Thank you
very much.
Thank you.
And the next presentation is by Dr. Siddiqui Parvez Ahmed, role of Ayushman Bharat Yojana in ophthalmic science. Siddiq is here. Prevention and investigation of post-procedure ophthalmic infections.
A very good afternoon to all present here. I'll be speaking about the prevention and investigation of post-procedure ophthalmic infections. Let us start by looking into the various sources from which infection can get transmitted during a procedure. So the sources are environment, instruments, medicines or washes, disinfectants, patients or healthcare workers. And the prevention of post-procedure ophthalmic infections, it essentially involves taking care of all these sources of transmission of infections. So for environment, it is important to maintain a good quality air in the procedure room, and HEPA filtered air, which is the one which is recommended for all the procedures. Optimum temperature and humidity also needs to be maintained, and the surfaces should be disinfected as per the recommendations of infection control team. If these things are taken care of on a routine basis, fogging is not required, and for quality control of these three, we need to do the maintenance of filters. We should maintain log of surface disinfection. Checking of the quality of air can be done by using the settle plate method, and also by taking culture of the surface swabs. All instruments and drapes which are being used in the procedure should be properly sterilized, and the quality control should be maintained by using chemical or biological indicators. Also, at the time of using, intactness of packaging or seal should be checked by the user, and in certain sterilization methods like autoclave, the date of sterilization should be checked. Also, the random articles can be opened and cultures of swabs can be taken. The medicines or washes, etc., they usually come as pre-packaged consumables. So the user should check the seal and date of expiry, and also it should be physically examined before use. And the manufacturers of the instructions of the manufacturers should be followed for usage, dilution and storage, and random batches can be opened and cultured to look for any possible contamination. All the in-house preparations, if used, they should be checked batch to batch wise before releasing them for patient care. The scrubs and disinfectants, they also come as packaged consumables. So all the three things, checking the seal and date of expiry, physical examination, and following manufacturer's instructions. They stand for them as well. Also, the components and the percentages of different components of disinfectants should be checked before releasing them for patient care. In patient, the comorbid conditions and the medications, etc., should be properly looked for, and adequate control of the comorbidities as well as stoppage of medications, if indicated, should be done. The infections in the vicinity should be treated before doing the procedure, and part preparation should be done adequately as per the standard procedure. The healthcare workers need to maintain a proper procedure room etiquette, hand hygiene. Following all the steps of hand hygiene should be done by all as frequently as required, and the standard procedures should be done at all times. Despite all these things, if a post-procedure infection does occur, then how do we investigate it? In the first place, why do we need to investigate a post-procedure infection? We need to do it to find out the possible source of infection so that we can control the source and stop the occurrence of further cases. And also, during the investigation, we can find a lot of other errors which can be timely rectified for the infection control in future. So the first thing which we need to do in case of any post-procedure infection is to review all the reports of infection prevention in the concerned period. For environment, all the reports of air quality and surface disinfection need to be relooked at. For instruments, the indicators and the cultures of swabs. Also, the lot numbers and expiry dates of the medicines and the culture reports. For patients, we should relook into any missed underlying comorbidity, and whether it was properly controlled or not. We need to do some fresh investigations also, including repeat cultures of medicines and washes from the batch which were used in the procedure. For disinfectants, we need to look for the contamination, also for the effectiveness of the disinfection. And the samples from the infected site of the patients also need to be microbiologically examined for identifying the pathogen and managing the case. So whatever errors are identified, they need to be rectified and control steps have to be taken. For example, in one of our investigations, we found that the batches of povidone iodine and scrub, they were ineffective on the skin surface disinfection. So these batches were called off from all the patient care areas, and the patient who underwent procedure with the disinfections using above lot were recalled and inquired about possible symptoms of infection so that they could be properly managed in timely manner. At our center, all the procedure-related infections need to be notified to the Infection Surveillance and Monitoring Committee, and a documentation of the occurrence of infection, all the investigations, follow-up, control steps, etc. is done and filed. So these are the forms which we fill as a part of the post-procedure infection investigation. This is the Form A, in which the presenting features of the patient with infection as well as the details of the procedure, etc. are there. And this is the Form B, in which the daily follow-up of the patient's condition, improvement, medications given, any reports which are coming in, all those things are maintained on a daily basis. So I acknowledge the efforts of ocular microbiology team and infection control team in management, prevention and control of all the post-procedure infections in our center. Thank you for your kind attention.
Next presentation is by Dr. Ravi Kiran Potleri, unprescribed medications and off-label drugs. Dr. Ravi is there? No. So we have some time, we can use it for discussion purposes. Dr. Soumya is here? I want to add regarding the residency training, what you have put, the Oscar score and basically the basically the problem in our country is that we don't have have problems with the infrastructure, and we have problem with the even with the HR. Problems in the infrastructure that we don't have the wet labs in all institutions where the postgraduate training is being conducted. And number second is the good microscopes, even the observers and even the recording systems are not in place. And number second is the senior, even the postgraduates are allowed to operate under guidance of senior residents due to lack of adequate faculty. And even the faculty is not ready to supervise the surgeries. What's your take on these points?
In our setup, like we make a postgraduate to do under a microscope which has the observer eyepiece. So at any given point of time, they would be operating and one person would be observing their cases. And what we also make this one is we have a recording system. We have a TV which we ask the other first years or who's not operating to record it, and then we observe it after the surgery, just after the OT, after all the cases are over. And that also, or based on that also, we do give a feedback. And
my point is in a general perspective,
yes, sir.
Nationwide, I am telling.
Yes,
I am not restricting it to your
yes,
institution.
Yes, sir. Yes, sir.
I think what I have
yes,
said
sir.
holds true.
Right.
In majority of institutions.
Right. So that's what standardizing the microscopes, and you help with the help of observer piece, and also a good OR recording system goes a long way, because definitely we do have more camps coming in most of the institutions, and all the camp surgeries and people from far off places are being carried to the hospitals for getting cataract surgeries done. So obviously the number of cases operated by residents are also increasing nowadays, because they would definitely want to go into a place where the number of cataract surgical CSR is also definitely high. So
comments?
No. Madam is only emphasizing on cataract. But
no,
now
sir, I mean generally.
exactly, we are emphasizing on that point. But now so many subspecialties has come up in ophthalmology. So many subspecialties are there and they are doing their thing. Definitely cataract is our bread and butter with IOL and everything. Whatever you do a private practice or anywhere, any corporate, they will be numbering the cataract IOL, how much you have put, how much multifocal IOL you have put, or prime IOL you have put. Okay. But in the training, we have to do cataract, and along with that, these hospitalities are also important, to whom we have to emphasize. Thank you.
Thank you, sir.
We can discuss something about the Nishant. Dr. Nishant, are you there? So, your is a post-procedure ophthalmic infections. So, when you think of infection is there, is it in the next day, within 24 hours or 48 hours, or what is the standard protocol for your?
So the standard protocol is that in case we are doing a superficial procedure, then it is 1 month, which is taken as a post-procedure infection. And if we are putting something in situ, for example, an IOL, then 1 year. It becomes larger because there are no definitions for ocular infections per se. So it becomes larger if we are placing an IOL in a cataract surgery. But this is what is generally considered. Many times we see that a patient is turning up after 6 months of a cataract surgery, but we investigate it to say that no, the infection is not related to the surgery which was done. This is what we are following.
Immediate, within 6 hours, within 24 hours, in the next day, or in a camp
So,
or in a
camp set. Pardon me, sir?
Post-operative endophthalmitis.
Post-operative endophthalmitis is the most common which we are seeing, sir.
So that you cannot wait for 6 months, 3 months, 2 months.
No, sir, we are not waiting. Whether to call it a post-procedure infection or not, so from the next day to 6 months, whoever is turning up is a post-procedure infection.
From the next day, when you are planning, the patient has gone to his home and has come. So how do you collect? How do you keep the Provident iodine with you? What are the used, or the IOL which has not been used, or what are the solutions, whether it was sterilized or not? How could you know? I
So
have to attribute to
because
those
whatever.
only for the batch number you are attributing. I am not telling a batch number. A same batch number, maybe somebody infected, somebody not infected. All these.
You are right, sir. That is why we are doing an investigation to find out whether actually it is the cause or not. Because most of the patients, they turn up within a month. So that batch may be lying somewhere. If it is
No,
not
no,
there,
it will not lie. Because the sister will throw it. So it will not be lying. It will
Sir,
not be,
if it is there,
cannot be
sir,
traced.
yeah, there are logistics, sir. If it is there, we will do it. We will culture it. If it is not there, we will have to say, like we have to exclude things like after investigation. This is what I want to say.
After 24 hours, after 48 hours, the patient is coming to you. Your sister will not be keeping the same badge, same cap, or the same thing which was used
sir,
for the person, for that particular person.
Okay.
So if 10 persons were operated in a particular day, suppose 2 or 3 are infected. So you have to be specifically for that thing. So how do you specify these 3 from the rest 10? The 7 are okay. Only 3 have been infected.
Sir,
So we do not use every time the same thing. Even the faculties are not changed every day. Every person we are not changing. Even if it is in the book teaching or the AIOS guidelines say, you change your drapes, you change your gloves, you change your everything. But sometimes it's not done practically in all the institutions all over India. So if a post-operative endophthalmitis occurs in a particular patient, how do you handle these cases?
sir, first thing is we see the presentation of the patient and we see the reports. For example, for each week or each day we will have the runs. Autoclave was run properly or not, whether the controls have been checked, what was the lot number and expiry of the consumables which was used, and for example, what were the culture reports that day. So the first most important thing is we relook into what happened on that day. Anything, ma'am?
Maybe I would just say, like you said, you would see for a year. You can say that it is either acute or chronic endophthalmitis, and based on that, you would have your investigations done. As he said, that you won't be keeping the same vials, I agree. But then what you said, I agree to that you would check the batch number and expiry. And you would send those for cultures if required. If you have 3 cases, probably it's like a cluster end-off. So you'll have to take care of the cluster end-off. But if it is just one infection, then you will be investigating that, your protocols also, whether they were followed or not, and all other things.
You are right, ma'am. Actually, the investigation form and the follow-up form is general. So it might change depending upon what scenario we are encountering. So, for example, when the povidone was found to be not effective, in that time we had 4 or 5 cases together. And then we immediately recalled it, and we also talked to the patients who underwent procedure with the same disinfectant used. However, whether all the patients are getting infected or not, that also depends upon a lot of other things. How the patient's immunity is, who performed the procedure. So there are a lot of things which we may not be able to control and correct, but there are 60 to 70% of the things with the proper investigations, they come into place, and like we are able to tackle.
Thank you very much. We have been okay. Nice seminar, nice paper. All the speakers are there. No? Shall I request all of you to have a photograph so that I can have a memory for that?
I would just say just one for finances. What I learned during my fellowship days, you should keep 6 months of amount for reserve. Oh, okay. So 6 months, that's how COVID actually, so that you can tell your staff you have money, and that is what we have told our secondary center staff, don't worry about your salaries. We can, even if we won't work, we'll be able to give you full salary, no deductions. And that actually changes perspective. They are working same way, you know that. But then that has just changed. We thought that, they are there anyway in the system, but now they feel that yes, we are there to take care of them. So keep 6 months salary, 6 months reserve for, yeah.